Hey everyone, and welcome back to Anesthesia Learners Academy. Look, if you're a PG student trying to absolutely nail regional anesthesia for your boards, or just out there in clinical practice, you are in the exact right place. Today we're bringing you a super high-heeled explainer entirely focused on ultrasound-guided upper extremity blocks. We're literally going to map out the brachial plexus from the neck all the way down to the forearm, just making those complex anatomical pathways totally accessible. So let's just dive right in.
Real quick before we start, just our standard medical disclaimer. This explainer is strictly for educational purposes. Think of it as a high-yield review tool. It definitely does not replace formal clinical mentorship or your institution's guidelines. So, always double-check your local protocols before you actually practice these techniques on the floor.
All right, so here's our roadmap for tracking the brachial plexus from proximal to distal. We just knocked out the welcome and disclaimer. Next up, the interscalene block for the roots, then supraclavicular for the trunks, infraclavicular for the cords, axillary and distal terminal branches, and finally we'll wrap up with a high-yield summary. Let's get to it.
Section 1. Interscalene, the roots. Intercepting the roots.
So when you drop that high-frequency linear probe transversely right on the neck, you're hunting for a really classic visual mnemonic. We call it the traffic light, or sometimes the snowman sign. You'll see these hypoechoic, dark, round structures, and that's your C5, C6, and C7 nerve roots. They're just sitting there perfectly stacked, right between the anterior and middle scalene muscles. Honestly, the second you spot that traffic light, boom, you're instantly oriented to the proximal brachial plexus.
For the actual procedure, you're generally going to use a lateral to medial in-plane approach. You're going to feel this really subtle pop as you pierce the prevertebral fascia. But listen, here is the absolutely crucial step. You have to stay outside the nerve sheath. It's so important because studies looking at dying cadavers show that if you inject even a tiny amount inside that sheath, it can force the local anesthetic right into the fascicles, and that causes major chemical and mechanical nerve injury. No thanks, right? So instead, just drop your 10 to 15 milliliters of local right next to the sheath. I promise it'll diffuse perfectly. Now, obviously, the neck is a super crowded neighborhood, highly vascular, lots of nerves. So we've got to talk about the interscalene danger zones. Because the phrenic nerve rests literally right on the anterior scalene muscle, it's pretty much guaranteed to get blocked if you're using typical volumes. That causes hemidiaphragmatic paresis. Translation, you definitely want to avoid this block in any patient with severe respiratory issues. Also, keep an eye out for the vertebral artery, watch out for sympathetic chain blockade, which gives you Horner syndrome, and just make totally sure your needle doesn't accidentally traumatize the dorsal scapular or long thoracic nerves as they pierce through the middle scalene.
Section 2. Supraclavicular, the trunks. Bundling into trunks.
Okay, so if the interscalene is a traffic light, the supraclavicular level is famously known as the bunch of grapes. As you slide your probe down into the supraclavicular fossa, right over that first rib, the plexus actually tightens up. It forms this incredibly compact, almost honeycomb-like bundle of trunks and divisions. And you'll see these hypoechoic grapes positioned really nicely, lateral and superior to the dark, pulsating subclavian artery.
Now, really understanding these two locations is what dictates exactly why you'd pick one block over the other. Your interscalene block, that's your absolute gold standard for shoulder surgery. But since we're mostly targeting C5 to C7 there, it heavily spares the C8 and T1 roots. Which means, yep, it totally misses the ulnar nerve distribution down in the hand. The supraclavicular block, though, grabs that whole compact bunch of grapes. So it gives you this really rapid, dense anesthesia from the mid-humerus all the way down to the hand. The catch? It often spares the suprascapular nerve, so it's kind of incomplete if you're doing shoulder work.
Moving on to the danger zones here. The big one, the one every PG student dreads, is a pneumothorax, because the pleura is lurking just deep to that first rib. Honestly, the safest technique is to bring your needle down and literally rest it directly on the first rib. Let it act as your backstop. Under no circumstances do you advance past that rib. Oh, and definitely throw on color Doppler before you even insert your needle. You really want to avoid puncturing the subclavian or the transverse cervical arteries, which keeps your risk of local anesthetic systemic toxicity nice and low.
Section 3. Infraclavicular, the cords. Reorganizing into cords.
All right, diving deeper. Down at this level, the cords are named based on how they relate to the axillary artery. So we have the lateral, posterior, and medial cords. To block these guys safely, we're going to use a steep in-plane parasagittal approach just medial to the coracoid process. Now pay attention here. You absolutely must pass your needle tangentially past the lateral cord so you don't impale it. Your ultimate destination is right at that 6 o'clock position directly posterior to the axillary artery. By hydrodissecting step by step with your local, you're going to create this gorgeous U-shaped spread underneath the artery. It reliably pushes the cords away and just bathes all three of them at the exact same time.
Section 4. Axillary and distal. Terminal branches.
Okay, so once we make it into the axilla, those cords separate out into their terminal nerves, and there's this fantastic clock-face cognitive framework we can use to map them right around the axillary artery. The radial nerve, it sits deep, between 5 and 6 o'clock, right on the conjoint tendon. The median nerve is hanging out between 9 and 12 o'clock, pressed right up against the coracobrachialis muscle. Then you've got the ulnar nerve, typically over between 1 and 3 o'clock, superficial to the radial nerve. But hey, don't forget, you're also going to need to hunt down the musculocutaneous nerve separately. You'll usually find it sliding right within that coracobrachialis muscle.
Now I know what you might be thinking. Do I seriously have to hunt down and individually inject every single one of those nerves? Well, not necessarily. The experts over at NYSOA champion this brilliant KISS principle. You know, keep it simple, stupid. By just passing your needle behind the artery to fill up the posterior space, and then going above the artery to fill the anterior space, you effectively flood the fascial compartments that house all those nerves. It's a game changer. The fewer needle passes you have to make, the lower your risk of unintended vascular or nerve puncture. Makes sense, right?
But let's say your surgeon just needs to pin a single finger, and your patient really wants to keep their shoulder and elbow mobility. What then? Distal terminal branch blocks are your best friend here. You can selectively block the radial nerve right in the fascial plane just above the elbow. And for the median and ulnar nerves, target those in the mid-forearm. Since these are fascial plane blocks, you just slip your needle right next to the nerve, straight into that fascial envelope, and deposit maybe 3 to 5 milliliters. It gives you this fantastic motor-sparing surgical anesthesia plus prolonged analgesia for those isolated hand surgeries.
Section 5. High-yield summary. Review and sign-off.
To wrap this up, just try to picture the brachial plexus like a giant neural highway. Starting up in the neck, you've got the roots at the interscalene groove. Remember that traffic light, absolutely perfect for shoulders. Moving down to the collarbone, those roots weave into trunks at the supraclavicular fossa. That's your bunch of grapes, which is incredible for total arm coverage. Going deeper into the chest, just below the clavicle, you'll find the cords arranged around the axillary artery. And then finally, as we hit the upper arm, those cords divide out into the terminal branches for your axillary and distal blocks. Truly, linking that anatomical structure to the sonographic location is the major key to nailing your PG board prep.
Before we go, I want to leave you with this thought to chew on. Anatomical variations in the upper limb, they are the rule, guys, not the exception. So how are you going to tailor your next distal block to navigate your specific patient's totally unique neural mapping? It's something you always got to be thinking about. Just keep scanning dynamically, trust your fascial planes, and above all, keep learning. Now, if you found this explainer helpful for your studies, please don't forget to hit like, subscribe, and definitely share this with your peers on the Anesthesia Learners Academy platform. We will catch you in the next explainer. Keep up the awesome work out there.